And it also gives me a great pleasure to introduce who I consider both a friend and a colleague who have walked a long road together. She has boxed in our gym, she has boxed with us, she has boxed us, and and you'll see the back of my shirt is the theme song from our gym. It comes from Faithless God is a DJ, which says, "This is my church, and this is where I come to heal my hurt." And the boxing gym is certainly that for us, and I know for Danella similarly so. Welcome, Doc.
So my name's Danella, and I'm a psychiatrist. So I'm a medical doctor who specializes in psychiatry, and I'm just going to be giving a perspective in terms, as a psychiatrist, in terms of where we fit in suicide prevention and sort of the diagnosis and treatment of mental illness. So if we can just move to the next slide. So what we do, pretty much we diagnose, and I think something that's been mentioned is the limitations of our diagnosis, and the fact that our diagnoses sometimes don't matter. They matter for research, for insurance, we need a sort of diagnosis to claim from a medical aid, but at the end of the day, what we're treating are humans with symptoms, and maybe for the purposes of this discussion, that's a lot more important than the nitty-gritties of the actual, illness itself and the diagnosis, but so some of the disorders or some of the symptoms that somebody presents with, which could lead to them ultimately feeling hopeless enough to want to hurt themselves, examples, depression, anxiety, even ADHD, substance abuse, sleep disorders, those are all things that would increase one's risk of suicide. So a lot of these are actually treatable illnesses, and they're illnesses which, and I think one of our speakers spoke about access to the right help, and that we don't have enough psychiatrists in this country, and we don't have enough access to mental health care, because a lot of these illnesses are actually something that we catch them early and we treat them. We can really intervene, and people can do quite well. I mean, if I give an example, ADHD, it's an illness which, by which a child may not concentrate so well, but that can lead them to having low self-confidence, that can lead them to feeling different, not doing well at school, feeling like a failure. And then again, boys don't cry, so we have to kind of keep this all to ourselves and just suffer on. So we suffer on, we get anxious, we get depressed, and then we turn to substances because we're self-medicating our concentration. We also self-medicating because we don't feel good inside. Wanting to run away from our problems, we stop sleeping, one thing leads to another. And it's quite sad that something as simple as treating a kid who's struggling to learn with medication that will actually possibly solve most of the problem, yet most kids will not then have access to services that can provide this. So if we're just moving on to the next slide, I think important to mention when we're talking about mental illness or various factors contribute to somebody's developing what we want to call in inverted commas mental illness. That some people, there's a family history, so there's a genetic predisposition, their environment, and I think that's been spoken of a lot in terms of trauma, abuse, bullying, even neglect. So sometimes neglect is actually worse than abuse, and worse than the parent that hits the child is the parent that doesn't hear the child. Trauma actually interferes with your brain's fight or flight response. It actually rewires your brain in a way that predisposes one to developing a bit of a poorly wired brain or differently wired brain, and I'm going to go into that just now. Then we've got things like head injury and concussion, and those are things I think that resonate to us, me being a retired fighter, that head injuries and concussion, many of the people that I used to train with and sort of us older retired fighters, we end up depressed, we end up using substances, and we kill ourselves because of it. Often medical illness, pain predisposes one, so these are all risk factors for developing mood disorders, and ultimately those are as a result of brain dysfunction. So I think what's important to mention here, and Dee mentioned that we want to demedicalize on the one hand, but on the other hand, we also want to medicalize, and we also want to say that mental illness, it's an illness, like having a cold and like having a broken leg. There would be no shame in having a broken leg and going to the doctor. Where, often people who are struggling with symptoms of mental illness will then not want to talk about it, not want to see the doctor, where it's actually, really, it's a medical illness, and often a patient will come, and spoken of earlier about I've got palpitations, I want to go to the cardiologist, or I feel tired and I can't sleep, let me go to a physician, and here maybe there's something wrong with my hormones. I often get those patients sent from the physician saying, well, there's nothing wrong with him, and they go, doctor, it's just, it feels like no one's hearing me because something is wrong with me. everyone is telling me I'm fine and nothing is wrong with me. And I'm saying, of course something's wrong with you. The symptoms you're having are absolutely not normal. You shouldn't be having them. There's something wrong with your brain. It is an illness. It's just as valid as a thyroid disorder. So I think medicalizing it and seeing its sort of biological basis is also something that's quite helpful. And something our previous speaker spoke about, but just to reiterate how we sort of how a person can end up feeling suicidal. One doesn't always have to be mentally ill. And I think that's also quite important, that it's not because somebody committed suicide or tried to commit suicide that they're mentally ill. It can be almost a normal response to an abnormal situation. And this is just one of the, so somebody might come with low mood, and typically we associate depression with a low mood. I have especially when we talk about men and men's mental health, often a male patient will come to me and completely depressed. I see them as a severe depression, and they will say, I do not feel depressed. So, doc, what are you talking about? I don't feel depressed. I'm angry. I'm not sleeping. I don't enjoy anything that I used to enjoy anymore. I don't want to see anyone, but I'm not depressed. I'm angry. Or I feel nothing. I feel numb. So I think there's, a lot of misconceptions around what should you be feeling to seek help. But low mood or sadness is maybe one way somebody could present. Again, that fight or flight, increased anxiety, problems with sleep, then leading to substance abuse, poor memory and concentration, poor judgment and impulsive decision making. So it's almost all this whirlwind, a snowball that escalates. Then one starts to almost no longer be able to make decisions, to judge. We start to become quite impulsive, and then we stop being able to think how to solve our problems. We're in a hole, we're just falling deeper into this hole. We're not seeing that there might be a ladder. Because now we're just drowning in everything, and that lack of ability to access the coping mechanisms, then we're ultimately feeling hopeless, we're feeling overwhelmed, desperate, and that's when it feels like there might not be another option. Intervening earlier in the cycle while the person can still think, and I think that's the key, while they can still access their coping mechanisms, that would be the key, because by the time they're feeling that hopeless and desperate, they're probably really, really unwell at that point, and their risk of hurting themselves and needing actually medical care at that point, it has escalated. So this is just an interesting place. This is Greenland. So this is a place that I went to. So it was said, like the South African Depression and Anxiety group, I went to a place called Disco Bay. And I had a little paper that said mental health matters, and I was going to take a photo for them there. I think they had people climbing Kilimanjaro and people doing all kinds of things. So that was, but interesting about Greenland is they have the highest suicide rate in the world. So I just thought interesting to talk about it and why. So it is a beautiful place, but it's dark for 6 months of the year. People sleep messed up. I mean, their sleep routines are completely out of whack. A lot of alcoholism, a huge amount. They just basically sit in the dark and drink for 6 months. They're very isolated. I mean, I had to catch a cargo plane and another cargo plane, and for me to get to Disco Bay was, and even if you want to go visit someone who's in another town, it's by plane. There's sort of, you can't drive between cities, and they also, when we talk about sort of colonialism and those struggles, they were colonized by Denmark, and they're still not really uncolonized. So they kind of are Greenland, but they're also part of Denmark, and culturally Denmark and Greenland are very different. So in terms of their identity as a nation, they're really sort of struggling with that. So I think that lack of connection, the loneliness, the isolation, sitting in the dark, substances, and they're literally a recipe, a pressure cooker for mental health issues and for suicide. So this is an infographic, sort of American Psychiatric Association, in terms of when do I need help. And I mean, it's a helpful infographic, but I mean, I think it's really, the hard part is everyone asks me, where's that line between a bit sad and I need to see a psychiatrist? And often I say, well, wow, that's $1 million question, and we'll take questions afterwards. Very, very difficult question, but I get asked all the time, kind of where's that line between I'm having a bad day and I need to seek help. And I think for me that the key is sort of when you start being able to think for yourself, and you start needing someone to help think for you, you should maybe ask somebody to think for you and to help you think. And these are just some of the sort of symptoms of depression, but I think this infographic gets helpful, but maybe doesn't paint the whole picture. And just some tips. I mean, people are often very nervous to come and see me. Everyone sits down and goes, oh, doc, I really didn't think I'd ever end up here, in a psychiatrist's office. I'm a real branch purchase. It's the last place I wanted to be, but they said I had to see you. My wife told me I had to see you, she should divorce me. My doctor told me he can't help me anymore. So I mean, I get that people don't want to be there, and they're often actually very nervous to see me, and they think I'm going to, lock them up, or I'm going to, medicate them, and I think we've got all kinds of, horrible stigma. And often the journey will start with talking to a primary care provider, because as lots of our speakers have spoken about, you won't just go straight to a psychiatrist. And sometimes bringing a friend or relative to a session is a good idea, because they can remember, they can think, they can say, hey, but did you tell them that you were on this medication before? And being honest, I think people often don't want to tell me things, it's a lot of things that they might be ashamed of. And it's for me to sort of win over their trust and to build the trust that they would be willing to disclose things. But often you can't really tell me anything I probably haven't heard worse. And be able to ask questions. I think that's the most important thing, that you need to ask your doctor questions, because it is your body and your brain. And I do not get annoyed. Ask me everything. What are the side effects? Why are you giving me this medication? Why aren't you giving me medication? How does this medication work? Draw it for me. I don't mind. So I think very, very important, anyone who is seeing a psychiatrist, that you need to be asking us questions until you are comfortable with what we're doing. And sometimes I will recommend something and you will not agree, and it's a dialogue, and then we sort of come to a middle ground. It's not that I'm the doctor, this is what we're going to do. This is what I suggest we do, you want to do this, let's kind of negotiate. So just in terms of the options that we have in treating mental health complaints, and the way a psychiatrist would do so is to see the person and do a thorough assessment, take a history. Often we have to speak to sort of people around them to get a full picture. And we basically are formulating a treatment plan in order to correct any brain dysfunction that is there. But that doesn't solely involve medication or medical means. And I think the other speakers have spoken about the support system. Those around you, your context. We will not get somebody right. If a person's in a context or a system that is dangerous, if they are being abused or their life is in danger, not much a psychiatrist will be doing to help them. We need to look at that context. We work with a team, so we can't do it alone. Medication is one option, and not always an option. So I think psychiatrists have a bad rap. If you're going to go to the psychiatrist, you'll get meds, but often you go to the psychiatrist to be told you don't need meds. And I've often got patients referred to me on meds where I say, well, you went onto meds because you went through a traumatic experience, you lost someone. This is a normal response to an abnormal situation. It is normal to feel hopeless and despair and grief, and you don't need all these medications. It's actually numbing you, maybe you're not processing this grief, and to de-prescribe. So I think there's a myth that we just want to pile on the meds and numb people out. Often it's the other way around. Psychotherapy is one way to help them coping mechanisms, and I think that Luke makes an important point. It's not for everyone, so we sort of think everyone must go to therapy and talk. We get people who aren't talkers, and then we've got to think that for them will be like torture, to sit and talk. So there's other ways that we can do it. Equine therapy, sometimes horses are better therapists than humans. Art therapy, and this is my church, this is where I heal my hurt. So to come to a place where maybe you're just going to participate in a sport, lifestyle, exercise, hobbies, diet. So, those are all parts of the treatment of mental illness. And I think just Tyson Fury, I'm very grateful to him. I'm a huge fan of his, even just as a boxer. But I think what he did for us when he spoke was incredible. He was quite an unwell man, and I think there were pictures of him with a big book and a complete mess. And he got himself sorted out. He was suicidal, he was depressed, he was manic, he was anxious, he was using substances, and he fought his way back to fight and win quite a beautiful knockout. And I think he continues to inspire, because he's also, when we talk about gender stereotypes, could you get more of a man's man, this massive Irish traveller, and he's just blown the stereotypes out the water, and the fact that we all admire him. I really am very grateful for him for speaking out and for actually also showing us that you can get better. And I think that that's, you know, that people do come back and that they win. They win at life, they win at sports, yeah. So often people ask me, you know, what are the warning signs? How do I know if somebody's at risk of suicide? And I mean, again, American Psychiatric Association, this is a helpful infographic, but it's also maybe somebody who won't present like this. People who maybe look absolutely fine, and the next thing you hear, they're dead. So, you know, talking about wanting to die, guilt and shame, making a plan, it's all very well and good. This is helpful. You know, somebody who presents with these symptoms probably is at risk, but I think sometimes we don't know who's silently suffering because they're silent, and I think that's what makes things so hard. Yeah, so I think on, and just in terms of, you know, those of us are sitting here thinking, how do we help someone who's thinking of suicide? Not as simple, you know, but one thing that's important is just asking somebody if they're suicidal doesn't give them the idea. So I think there is a bit of a misperception that if you're going to mention it, maybe then you'll give them the idea. And it's not, just ask, are you suicidal? Because, you know, sometimes when things are really bad, you wish you were hit by a bus. That's okay, talk to me, you know. It's, and talking, reaching out to people's stigma. So I think that stigma and misinformation, so stigma against sort of mental health, against seeking help, but also misinformation about mental health, that you've got to be crazy, or you've got to be nuts, or you've got to be medicated in a straitjacket. I think addressing that stigma is important. Yeah. Paddy Pimbleton's again a little bit of a combat sports bias here, but he's in a UFC mixed martial arts fight, and he fought only just before he fought to find out a friend of his had committed suicide. And this he spoke after his fight, he was weeping. And this is a quote from him: "There's a stigma in this world that men can't talk, and I know I'd rather have my mate cry on my shoulder than go to his funeral." So yeah, he really, you know, again, when people like him speak out, it really helps all of us to know that, you know, men don't cry. That is absolute nonsense, and it's killing people. So thank you to Paddy. Yeah. So this is us here, quite a while ago. And I think when we talk about protective factors, or things that sort of protect against suicide, this place is actually maybe a great example of it. Here we can see we're exercising, so we're looking after our physical and mental health. Again, a protective factor against mental illness, which, you know, coping mechanism. So as Luke was mentioning, so many of us find going to therapy versus maybe coming to the gym and hitting a bag, this is our therapy, and that's okay too. Feeling like we belong. So this is quite a diverse group. You know, we all, a lot of the faces in this you know, we've got people from Congo, from Nigeria, we've got people from South Africa, we've got young, we've got old. So all coming together, just feeling like we had a common purpose and a belonging, feeling safe. So I think, you know, this is a very safe place. We all feel safe here. So I think that this is an example of an environment that is protective against mental illness and against suicide. So just, you know, again, to the myths and the stigma, those are the things that sort of are barriers to everyone getting the help that they need. We often perceive mental illness as a weakness or a defect, and it's not. I mean, if you have a broken leg, if you have diabetes, if you have high blood pressure, you wouldn't really say that it's your fault. So, for some reason, just because it's a brain disorder, that people must see it differently, and just because they don't understand it, they see it as, I don't know, a flaw, a weakness, a defect, and I think that needs to change because science tells us it's not. You know, the brain is an organ just like the heart. And this leads people to feel isolated and almost like lepers, you know, that they sort of have this disease that they can't talk about. And basically, you know, as I mentioned before, if we leave somebody who's struggling untreated, they sometimes spiral to the point where they're too depressed to be making decisions and thinking of solutions themselves, and this can end in catastrophe. So if we move on to the next slide, I mean, just to end off with this message, yeah, that sometimes the bravest thing you can do and the biggest fight you can win, whether it's in the ring or the cage, is sometimes to ask for help. So I just hope that you know, my message might be, you know, there's bravery in seeking help. So thank you so much for having me.